So, this will just be an overview of the top 10 diagnoses that you will see in acute care. So, the purpose of this is really just to give you a quick overview of these disease processes. It's not meant to go in depth, just to give you better preparation for clinical. So, congestive heart failure. What is congestive heart failure? Basically, it's when the heart muscle becomes really weak and it eventually then tires out the heart pump. So, basically, there's two components to the heart, there is the pump and the electrical system. So, in heart failure, that pump, the physical portion of the heart, starts to give out just because it becomes really weak. So, the walls of the heart will thicken and stretch out because it's trying to it thickens because it's trying to work hard to pump. So why do people get heart failure? So it can be caused by high blood pressure. And this isn't just, somebody has, high blood pressure that is new. This is like over time, long undiagnosed or untreated hypertension. Obesity. So when you have excess weight, your body has to work harder. Diabetes and high cholesterol. So some common medications that you're going to see for heart failure. You will see antihypertensives. So some antihypertensives are not really appropriate in heart failure. So we don't really use antihypertensives like your ACE inhibitors like lisinopril. We use more of like your calcium channel blockers, your beta blockers. So, like metoprolol, carvedilol, those are both common ones. Carvedilol more in like advanced heart failure. Diuretics, we see a lot of furosemide, so more your loop diuretics. If your patient fails on furosemide, you'll see ones like Bumex or torsemide as stronger diuretics that are utilized. So, diagnostics that we'll see when your patient comes in, they are going to typically look fluid overloaded. So, they'll have a lot of edema, so fluid in their lower extremities. Sometimes it's up into their abdomen. We'll see sometimes jugular vein distension, so kind of that, when they're lying back, they're going to complain of something called orthopnea. So, meaning that, when we're trying to reposition them, like laying down or sitting up, they're going to feel better sitting up. Laying down is going to be really, really hard because of all that extra pressure. They'll complain of shortness of breath, especially exertional shortness of breath. So let's say your patient tries to get up and walk across the room. They're going to become a lot more tired, fatigued, short of breath than they would if they didn't have that extra fluid. So the diagnostics that we'll see ordered, basic metabolic panel. So that's going to be their kidney function, which a lot of times with the extra fluid, we see that it can cause your patient's kidneys to be stressed out. So you'll see a bump or an elevation in that creatinine. You'll see a decrease in that GFR. So sometimes, and it can be kind of a vicious cycle, right? Because you're trying to get the extra fluid off by utilizing a diuretic, but the diuretic also stresses the kidneys out. So, for example, I actually am caring for a patient that recently I was trying to fix his fluid volume status. So this patient really likes to eat nuts. So we'll eat a lot of cashews, peanuts, things that are high sodium. And so he typically retains a lot of fluid. And so this particular patient had an 8-pound weight gain in 1 week. I could see that the patient had 2+ edema. So it was, really good pitting edema in his lower extremities. So at baseline, he's not on any diuretics. And so I gave him a 3-day course of furosemide to try to pull the fluid off. So I was successful in pulling the fluid off. However, in the meantime, his creatinine baseline went from 1.6, which does show that he has some chronic kidney disease, all the way to 2.1. So I stressed out his kidneys way too much. So then we had to take a break from the Lasix, but then he was back to eating nuts again. So it's kind of a vicious circle and can be really difficult to manage. You'll see that a BNP will be ordered. So BM as in Mary and BN as in Nancy. And that higher than the number, the BNP, kind of the more severe the heart failure is. Eventually, at some point in time during hospitalization, your patient may get an echocardiogram. This will show us, how well the heart is pumping. It's going to let us visualize the valves, just see where, there could be any problems. Chest x-ray, we do that right away in the ER. EKG, we usually do that right away in the ER. Nursing interventions, daily weights. So this patient should be weighed every single day before breakfast at the same time. Super important. So let's say they weigh, if you have this patient and they're weighing every day with shoes on, then you should be weighing that patient with shoes on. If they're weighing without shoes, you should be weighing without the shoes. Okay? Get all the stuff out of the pockets, pockets, purses, or wallets, purses. Those can add a little bit of weight. So you want to make sure that that weight is accurate. So sometimes if it seems that it's really high or really low, reweigh the patient. Sodium restriction. So my patient that I was telling you about that eats a lot of nuts, not a good thing. So nuts, chips, processed food. So like anything that comes like in cans, like canned vegetables, those freezer meals, those are all super high in sodium. So they do make some alternatives like low sodium soups, but they still do contain a lot of sodium. Fluid restriction. So of course, when you tell a patient like, hey, you can only drink 3 mugs of water a day, all of a sudden they want 6 mugs of water where previously maybe they had 1 or 2. It seems like patients will feel thirsty when they know they're on a fluid restriction. So some ways you can help the patient, you can give them, like a sugar-free candy to keep in their mouth to keep it moistened. You can use Toothets, things like that. And then medication compliance. Super important that your patient continues to take their medication as ordered. Just because if they stop taking their medications, that's going to lead to heart failure exacerbation. Chronic obstructive pulmonary disease, so COPD exacerbation. So what is COPD? It's a disease caused by obstruction to the airflow in the lungs. So the tubes that go into the lungs, they become really obstructed. People with COPD, most of the time it's caused by smoking. Now there is kind of an exception to that, and there is some people who are genetically prone to developing COPD or emphysema, and they've never been smokers. It's super unfortunate, but smoking is the number one cause of COPD. So what do these patients look like when they are having exacerbation? They will complain of shortness of breath. These patients with advanced COPD will have something called barrel chest. So they may have like super thin extremities and have like a big chest. Again, for these patients, we see a lot of times exacerbations caused by like respiratory illnesses. So something like the common cold, to somebody who doesn't have COPD, they can fight it off. For somebody who has COPD, they'll end up becoming extremely sick. Medications. Short-acting bronchodilators. So that'll be like your albuterol. And then This patient typically is on a long-acting bronchodilator. So that's more of like maintenance medications. We do see that these patients get high doses of corticosteroids while they're in exacerbation, antibiotics, typically with like macrolide antibiotics, so like your azithromycin is a common one, but we give them super high doses of corticosteroids while they're hospitalized. The other medications that you may see, we give them usually a mucolytic, such as like a Mucinex. So with diagnostics, we will typically see a complete blood count, a basic metabolic panel. We see ABGs just because we want to make sure that they aren't progressing towards respiratory failure. Chest x-ray, CT of the chest. A lot of times that's to rule out like a blood clot to the lungs, or it can help us identify like things like lung masses. So CT is helpful in that regard. Nursing interventions. I do mention the PFT. That's more for like patients who are like working in the clinic, or patients going to the clinic appointments. If you work in the clinic, you'll see probably PFTs. Interventions, we give them oxygen, but we have to be extremely careful because they do retain CO2. So they are carbon dioxide retainers. So if we give them a lot more oxygen, if we increase that flow rate, they have a hard time blowing off that CO2. So a lot of times in severe cases, you're going to see these patients on BiPAP. We do steroid management, exercise, pulmonary rehab for when their discharge is the number one thing for predictor of success. The other thing I don't have written down, but I do want to mention because it is that time, seasonal vaccinations. So the COPD patient, that should be the patient who is getting the influenza vaccine, the COVID vaccine, pneumococcal, RSV. Those seasonal vaccines are so important. Hypertensive emergency. So this is a blood pressure of 180 over 120 or higher. And so what it does is it can cause damage to the organs just because there's not good blood flow with hypertension. So what do we give this patient? We will give them antihypertensive medications. We'll do vasodilators. So a common one that we give in acute care is hydralazine, just because we have better control over slowly lowering the blood pressure. Diagnostics, this patient will have an EKG. We'll check their kidney function, so CMP. We typically check for heart failure, BNP. Troponins are another one that you'll see, and then chest x-ray. So nursing interventions, things that you're going to do, you're going to monitor the vitals, monitor for signs and symptoms that patient might have. So a lot of times with hypertensive emergency, patient may complain of like severe headache. And this is the kind of headache that doesn't go away with like your Tylenol, ibuprofen, because it's related to the blood pressure. So the only way we can alleviate the headache is to get the blood pressure down. And again, we want to do a really low, slow reduction of their blood pressure. You don't want to do it quickly. And then this patient's going to be on telemetry monitoring. So we're going to be monitoring their heart 24/7. So this is just going to pick up what their heart rate and rhythm is doing, and then we can just monitor closely. So pneumonia, that's another common diagnosis that you will see in acute care. So it is an organism that causes a respiratory infection. Pneumonias can be caused by viral illnesses, bacterial illnesses, or even fungal illnesses. So the patient's presentation, oftentimes they'll have a cough. It can be productive or non-productive. Oftentimes we see them with fever, weakness, fatigue, low energy. They may have some shortness of breath. It could be as advanced as respiratory failure. Common medications, typically we put them on antibiotics. You'll see your patient on dual antibiotics, so usually like a beta-lactam and a macrolide, steroids, bronchodilators, so a lot of nebulizer treatments with albuterol. They may need like an antifungal if it's fungal related. Some of the diagnostics, chest x-ray, we may look at the sputum, see what's growing in there, blood cultures, CBC, C-reactive protein, if your patient's super sick, procalcitonin, lactic acid, because pneumonia can lead to sepsis. Things that you'll do for nursing interventions, you're going to administer medications, have them do coughing and deep breathing, incentive spirometry, have them get up and move around, because getting up and moving around is going to expand those alveolar sacs. They may need oxygen therapy, and then again, medication compliance is important. As I mentioned, sepsis, that sepsis can be caused by, again, bacterial, viral, fungal infection that leads to a systemic infection that triggers the body's inflammatory cascades. We will do CBC, CMP, a CRP, so again, looking at that, or a SED rate, looking at that inflammation, procalcitonin. You'll do a chest x-ray, EKG, CT, a urine is another one, because a lot of times sepsis is caused by like pneumonia, UTI, and depending on the severity, early sepsis versus late sepsis will be then where your patient will be placed in the hospital. Lactic acid is something that we'll measure actually pretty consistently. You'll give your patient a ton of IV fluids, antibiotic therapy, so you're going to draw blood cultures first and then start antibiotic therapy with a broad spectrum antibiotic. They may need some vasopressors if their pressures are tanking, corticosteroids, and then nursing interventions, telemetry, monitoring their vital signs closely, respiratory monitoring. They may be intubated. Again, depending on the severity, you'll be doing very close monitoring of these patients, their blood pressure, their pulse. So typically these patients will have low blood pressure just because they're not perfusing as well. And then tachycardia, their heart's having to work harder to perfuse. You may or may not see a fever, so fever is really prominent in children, young adults, but in older adults, we see that these patients a lot of times will be, like confusion, mental status change. CVA, also known as stroke, it's a reduction or loss of blood flow to the brain, results then in brain damage. This can present as weakness, visual changes, sudden onset of slurred speech. Some of the risk factors would be hypertension, coronary artery disease. So we can give the patient common medications, TPA, so it's a clot buster. That's only if it's a thrombolytic stroke. If it is a hemorrhagic stroke where they are having like a brain bleed, then they cannot have TPA. Statins, anticoagulants, and antihypertensive medications. It's important to note that with these patients, we want to slowly lower their blood pressure because we need to have some sort of perfusion to the brain. So when these patients are running in the 150s and 160s systolic, that is perfectly acceptable because again, we want perfusion to go to the brain. Diagnostics, you'll see that they'll have a CTA, an MRI, we'll draw blood work, so like CBC, CMP, APTT, lipid panel, and inflammatory marker CRP. Nursing intervention, so TPA has to be initiated within 3 hours. Again, that's only if it's a thrombolytic stroke. Neuros, so you'll be doing frequent neuro checks. They'll need very aggressive physical therapy, occupational therapy, speech therapy, and then IV fluids. Acute kidney injury. This is basically an event that causes a sudden onset of kidney function. So this can be from, like, let's say dehydration. It can be from medications. Medications are a frequent one. It can be caused from illness. So some common medications that cause kidney damage, your diuretics, some of your antihypertensives, some antibiotics like vancomycin can be extremely hard on the kidneys. Diagnostics. So we are going to look at the renal function. You can do that with a basic metabolic panel. So we're going to look at both the function as well as the electrolytes. We'll want to get a urine creatinine, microalbumin, CT scan, and kidney biopsy if needed. It seems a little counterintuitive, but sometimes when your patient has a lot of extra fluid, sometimes you have to stress the kidneys out and give them diuretics. Insulin, depending on cause, IV fluids, and then dialysis. So we try to typically jumpstart the kidneys with IV fluids before trying dialysis, but dialysis as a last resort. So seizure, what is it? It is an abnormal brain nerve conduction causing a disruption in activity. Seizures can manifest itself as clonic-tonic, so where they're having stiffening of the muscles and shaking, all the way to absent seizures where they just kind of stare off, but there's no muscle shaking. When this patient comes through, typically if they're hospitalized, it's due to several seizures or a new onset of seizure activity. Common medications, we'll give them anti-epileptic drugs. So if it's an acute seizure, we give them like a benzodiazepine. And then typically they're maintained on a seizure medication like Depakote, valproic acid, things like that. Diagnostics, they'll probably do a head CT, an EEG, creatine kinase, so CK, CMP, and lactic acid. The big thing that you need to remember is seizure monitoring and seizure pads, so placing aligned pads along the bed, making sure that the patient gets up, and then reducing any stimuli that could potentially cause seizure. Acute coronary syndrome. This is when there is a decreased blood flow to the heart, causing symptoms such as chest pain, shortness of breath. Your patient may be really diaphoretic. And so, again, this is chest pain that is difficult to alleviate with rest. Some common medications that you'll see given right away, morphine, oxygen, nitrates, so nitroglycerin, and that's a vasodilator, baby aspirin. It'll be maintained. Then in the hospital, we'll look at other contributing factors. So your patient may get some antihypertensives, they may get lipid-lowering medications, and blood thinners. Diagnostics, so your patient will get a CMP, BNP, troponin, chest x-ray, EKG. Intervention, so depending on what those findings are, your patient, if they have a blockage, they may need like cardiac catheterization, but you're going to monitor vital signs, administer medication, administer oxygen, telemetry, and then controlled like ambulation, things like that. Diabetic ketoacidosis. This is a ketone overproduction brought on a lot of times by illness or stress. So we see that the blood sugar ends up being extremely high. So your patients with diabetes can have this, more common in type 1 diabetes. HHS is more common in type 2 diabetes, but your patients still can have diabetic ketoacidosis. So this patient will have extremely high blood sugars. They'll feel very weak. fatigued, polydipsia, polyuria, polyphagia. We see it sometimes with medication noncompliance. So some things that we give your patient, they'll be on an insulin drip. We give them IV fluids, typically aggressive hydration with IV fluids. And then, like I said, insulin. Bicarb is another one that we may give. You're going to do CBC, CMP, a urine. We'll check to make sure that this patient will be doing like hourly glucose checks. Telemetry monitoring, because they can have some alterations in their potassium. And then, once we can get the blood sugar at a stable level, then they can come off of the insulin drip and then go to injectable insulin.